Hi everyone, today we're going to do a video presentation to demonstrate your facial bone positioning, nasal bones, zygomatic arches, as well as your orbit positioning. So we're going to start with facial bones. So for the facial bones, our routine views that we're going to cover today is your lateral projection, your parieto-acanthial view or your Waters method, as well as your PA axial view. So in terms of setting up the room, what we need to do is we need to use a grid, and we also need to use an FFD that is 100 centimeters. In terms of your exposure factors, you could try using around 70 to 80 kV and maybe between 16 to 20 MAS. Remember to use radiation protection as well as to remove all artifacts from your patient's area of interest, which is your earrings and everything from the facial area. In terms of your clinical indications for facial bones, basically you are checking for fractures, neoplasms, or inflammatory processes of the facial bones, the orbit, as well as your mandible area. Okay, so we're starting with the lateral view of the facial bones. So basically what happens is, in terms of your patient positioning, the ideas that your patient can be lying down or can be erect or sitting. The idea is just so that your patient is nice and stable. What we're going to do here is we're going to oblique our patient. The patient's in an oblique position, and we need to turn the patient's head in a true lateral position. When you are turning your patient's head, you can just make sure that the area of interest is against the image receptor. So if it's the right, you would do a right lateral. If it's the left, you're going to do a left lateral. So how do we, what can we use? We can use your occipital protuberance posteriorly, and we can use the glabella or the nasion anteriorly, and just make sure that the distance is equal on both sides of the patient, anteriorly and posteriorly. Then we're going to use our radiographic lines. So what we need to use is our interpupillary line that needs to be perpendicular to your image receptor. Then we can adjust the patient's chin so that the IOML is also perpendicular to your image receptor, and we need to make sure that the mid-sagittal plane is parallel to your image receptor. Okay, in terms of centering, basically what we need to make sure is that we are centering at the level of the zygoma or the prominence of the cheek, midway between the outer canthus and the EAM. So I'm going to move my patient slightly back so that it's midway from the outer canthus to the EAM. So around that area at the level of the zygoma. Remember to place your marker. So because we're demonstrating the left side, you're going to place the left marker, and remember that you need to collimate. So it's four-sided collimation. Superiorly to inferior, I basically covered my frontal sinus area and my mandible, and then anterior I covered the patient's nose and just slightly behind your EAM area. So your evaluation criteria for your lateral view of your facial bones, in terms of rotation, you shouldn't have any rotation or tilting on your image. So how do we know whether there's rotation or tilting? If it's rotation, you'll have an anterior to posterior separation of your symmetric vertical bilateral structures. Example, your mandibular rami, which is around this area here. Also of your greater wings of the sphenoid. So ideally you want these structures to be nicely superimposed on each other. If there is an anterior to posterior separation, then that would mean there is a bit of rotation. If there is tilting, there will be a superior and inferior separation of the symmetric horizontal structures such as your orbital roofs as well as your greater wings of the sphenoid. So on this image you can see there is a slight rotation of the patient's mandibular rami, which could mean that there's a bit of rotation, and then your orbital roofs as well. You can see that your structures are not appearing nicely as a single area. Okay, in terms of your exposure, you want to have sufficient exposure to be able to see your maxillary area, also to differentiate between your soft tissue as well as your bone structures. No motion is evident when you are able to see sharp bony margins or outlines. Your area of interest, you should have superimposition of your facial bones, your greater wings of your sphenoid, your orbital roofs, your sella turcica, as well as your zygoma and your mandibular area. Collimation, you want to collimate so that you are including your frontal sinuses and your mandible area. So for this patient, superior and inferior, they could have collimated just to that area, and then anterior to posterior just to include the nose going slightly behind the IAM. Your centrality, you want to have your image in the center such that it is at the level of your zygoma. Your medical legal requirements, you should have your patient details, your hospital details, a permanent lead marker. You must check for any artifacts. Your area of interest should be included, and you should have four-sided collimation. Okay, so we're moving on to your parietal acanthion view or your Waters method. We're going to use a horizontal beam directed perpendicular to your image receptor. To start off, basically your beam is going to enter the patient's posterior aspect and exit at the anterior aspect. So in terms of positioning, what happens is we need to make sure that the chin is against the image receptor. So we adjust the patient's head so that the patient's chin is against the image receptor. From this position, we need to angle or extend basically the patient's head so that the mental meatus line is perpendicular to your image receptor. Now remember, this is your line from the chin to your meatus. So that line needs to be perpendicular to your image receptor. This actually allows for the OML to be at a 37-degree angle. Okay. From here, we also need to make sure that our patient's head is in the mid-sagittal plane. So we adjust our patient slightly in this position. And then to check for rotation, you can use your thumb and your fingertips. Place them at either side of your patient's face. Remember, be careful of how you're touching your patient as well. And then basically we just need to adjust the patient so that there is no rotation. So it should be an equal distance on either side of the patient. Okay, we need to remember that in terms of our centering point, so it's a horizontal beam directed perpendicular to your image receptor, and we want our beam to exit at the acanthion, so just below the nose area. Okay, and then remember your four-sided collimation, and we need to place a marker unreadable on the side that we are demonstrating. Okay, so your evaluation criteria for your parietal acanthial view or your Waters method. In terms of rotation, you should be able to see correct extension of the neck when the petrous ridges lie inferior or below the maxillary sinuses. No rotation is evidenced when you have an equal distance from your mid-sagittal plane to the lateral margin of your orbit on both sides. You should also have an equal distance from the lateral margin of the orbit to the lateral cortex of the cranium on both sides. In terms of your exposure, you should have sufficient exposure to differentiate between your bone structures as well as your soft tissue structures, and you should have sufficient exposure to be able to see your orbit as well as your maxillary region. In terms of your area of interest, you should be able to visualize your inferior orbital margins, your maxilla, your nasal septum, your zygomatic bone as well as your arches, and your anterior nasal spine. In terms of collimation, you should collimate so that you're including your frontal sinuses and you're just below your mandible area. And then right to left, you must include your lateral cortex of the cranium. So on this image, there's actually the lines again. Collimation could have been improved just to that area. Okay, centrality, your diagonal lines should cross at the center of the image, which should be at the level of the acanthion. In terms of your medical legal requirements, you should have your patient details, hospital details, permanent lead marker, and you should check for any artifacts. Your area of interest should be included, and you should have collimation on your. Okay, so moving on to your PA axial view, or what you guys know as your OF 15 degrees. The reason that it's an OF 15 degrees is that the beam enters from the occipital area, exits at the frontal area, and the 15 degrees is because our X-ray tube is angled 15 degrees caudally. Now remember, when you're doing a PA view, you are going to angle caudally. If you are doing facial bones AP, then you can actually angle your tube cranially. So since we are doing the patient PA or OF, we're going to angle the tube 15 degrees caudally. So in terms of your patient positioning, basically we need the forehead and the nose to be touching the image receptor. Okay, so that way, and from this position we need to make sure that the OML is now perpendicular. So we tuck the patient's chin slightly in from there so that the OML is perpendicular to your image receptor. We also need to make sure that our mid-sagittal plane is nicely perpendicular, and then you should not have any tilting or rotation. So again, you can place your hands at the sides of your patient's head and just make sure that it's nice and straight. Okay, so my patient looks nice and straight. In terms of centering, we are centering in the mid-sagittal plane at the level of the nasion. So we want our beam to exit at the level of the nasion, which is just basically midway between your eyes. Remember that you need to collimate, so four-sided collimation. And remember to place your marker. So your marker will be placed unreadable on the side that you are demonstrating. Okay, so the evaluation criteria for your PA axial view, or what is known as your occipitofrontal 15-degree view, in terms of rotation, there is correct CR angulation when the petrous ridges lie in the lower third of the orbital region. To move the petrous ridges away, you can angle your tube maybe about 25 to 30 degrees caudally. Okay, in terms of rotation, there is no rotation when you have an equal distance from the crista galli to the lateral margin of the orbit on both sides. Also, the distance from the lateral margin of the orbit to the lateral cortex of the cranium should be the same distance on both sides. You should have, or you should be able to see a symmetric appearance of your superior orbital fissures. In terms of your exposure, you should have sufficient exposure to differentiate between your bone structures as well as your soft tissue structures. You should be able to see your maxillary region as well as your orbital region nice and clear on your x-ray. Your area of interest, you should be able to see your facial bones, which is, you look at your frontal bone. You should be able to see your orbital rims, so that's your superior, your inferior, your medial, your lateral margins, your lateral cortex of the cranium, your maxillary sinus, your mastoid air cells, your nasal septum, your petrous ridges, and here you have part of your mandible. In terms of your lines of your collimation, you should have some four-sided collimation, superior to inferiorly. This is the area that you want to cover, and then right to left you should include your lateral cortex on both sides. Centrality, basically when you do your diagonal lines, the center of your image should be at the level of your nasion. In terms of your medical legal requirements, it's your patient details, hospital details, having a permanent lead marker, checking for any artifacts, including your area of interest, and checking that you have four-sided collimation. Okay, so moving on to your nasal bones, your routine projections or your routine views that you would do is your parietal or cantillon view, or your Waters method, which we have already demonstrated, as well as a lateral view of the nasal bones. So for the nasal bones, I'm just going to demonstrate how you would do your lateral view. Also remember that it's good to actually do both sides. So even though your patient has or the problem area is on the left side, you should still do the right side for comparison as well. Okay, so in terms of positioning for your lateral view of the nasal bones, basically your patient again in an oblique position, your patient's head should be in a true lateral position. So we're looking again at your interpupillary line that should be perpendicular to your image receptor. We adjust the patient's head so that the IOML is also perpendicular to your image receptor. Your mid-sagittal plane is parallel to the image receptor. The whole idea basically of nasal bones is just to get good collimation and then to give the correct exposure factors. In terms of your centering, I would say that you would center just at the outer canthus of the eye at the level 1.25 centimeters just below your nasion area. And then you place your marker readable on the side that you are demonstrating, which is our left side. And then it's very important that we collimate so that we get a good image. So that is more or less our four-sided collimation for this patient. Evaluation criteria for lateral view of nasal bone. In terms of your rotation, no rotation should be evident of your nasal bone. In terms of your exposure factors, you should have sufficient exposure or contrast in density to be able to differentiate between your soft tissue structures as well as your bone structures. But there shouldn't be any motion, and that's evident when you have sharp bony outlines or margins. Your area of interest that needs to be included is your nasal bone with the surrounding soft tissue structures as well as your anterior nasal spine. You must be able to collimate to include the nasal bone. When you center, you should center the image at the level just below the nasion. Your medical legal requirements is as we mentioned previously. Also, if you could please go through your tangential or superior inferior view. It's in your Bontrager, and I think you'll also find it online. So now that we're done with nasal bones, we're going to move on to your zygomatic arches. So your clinical indications to do zygomatic arches would be fractures, neoplastic or inflammatory processes. The idea or the views that we're going to do is your SMV, which is your submental vertex projection, as well as your AP axial view or your modified Townsview method. Okay, so we're going to demonstrate now the SMV or your submental vertex projection. This projection is actually very uncomfortable for your patient. So now when I'm demonstrating, I'm going to be as quick as possible. In terms of your beam, you're going to use a horizontal beam directed perpendicular to your image receptor. In terms of your centering point, we're centering in the mid-sagittal plane at the level about 4 centimeters inferiorly to your mandibular symphysis. So I'm going to try and position, and okay, so basically our patient is AP, so beam is entering from the anterior aspect, exiting to the posterior aspect, or your frontal to occipital, so your FO applies here. So what happens is we need to extend the patient's head and patient's neck so that the IOML is actually parallel to your image receptor. So it is very uncomfortable, so you need to be careful of how you do in this position, as well as to make sure that if it's a trauma patient, that your patient does not have any C-spine injuries. Okay, so let's try and extend our patient's head. So we're extending our patient's head. We want the IOML, which is this line here, should be parallel. So you even extend your patient's neck even further so that the vertex of the head is actually against the image receptor. And then in terms of centering, we're centering about 4 centimeters below or inferior to the mandibular symphysis in the mid-sagittal plane. Remember that you would need to collimate as well as place your marker readable on the side that we are demonstrating. Try and make sure that there's no rotation or tilting, and that's basically your SMV positioning. So the evaluation criteria for your SMV or your submental vertex view of the zygomatic arches, in terms of rotation, you should be able to see, or no rotation is evident when you are able to see your zygomatic arches bilaterally. And then in terms of positioning, there is adequate positioning when you are able to see that the mandibular symphysis is superimposed with the frontal bone. In terms of your exposure, you should have sufficient contrast and density so that you are able to see the zygomatic arches on both sides of the face. Your area of interest that needs to be included is the zygomatic arches laterally from the mandibular ramus. So from this area going all the way down. Remember to collimate to your area of interest, and your medical legal requirements is as mentioned previously. Okay, so now for your zygomatic arches, we're going to do or demonstrate your apiaxial view, or it's called a modified Townes method. Now, those of you that have been for your clinical practice of your skull would be more familiar with this view. So basically what happens is our beam is going to be entering from the frontal aspect of the patient, exiting at the occipital area of the patient. So for this view, basically we're just trying to demonstrate the zygomatic arches. Again, the angle that you, or the tube angulation depends on whether your patient can tuck the chin in or not. If your patient can tuck their chin in, then we're going to use a 30-degree caudal angulation, and that's to bring we're also going to bring the OML perpendicular to your image receptor. If your patient cannot tuck their chin in, then we are going to use a 37-degree caudal angulation of your X-ray tube. So for this patient, we assume that under the assumption the patient is able to tuck their chin in, so we are going to use a 30-degree caudal angulation. Okay, so basically we tuck the chin in so that the patient's OML, which is your radiographic line from your outer canthus of the eye to your meatus, that line basically needs to be perpendicular. So we can even tuck the patient's chin slightly more in. Okay, and then we need to make sure that our beam is directed in the mid-sagittal plane of the patient. There is no rotation or tilting, which we can just basically adjust the patient's head. And then we are cinching at the level in your mid-sagittal plane at the level which is about 2.5 centimeters above your glabella. So if we put our glabella to be around this area, it's about 2.5 centimeters superior to that. Okay, remember that you need to collimate, and we put our marker readable on the side that we are demonstrating. If we are doing a 37-degree angle where the patient cannot tuck their chin in, then we use your IOML. So your IOML then needs to be perpendicular to the image receptor. So evaluation criteria for the modified Townes view for the zygomatic arches or your apiaxial view, basically in terms of rotation or positioning, no rotation is evident when you are able to see a symmetric appearance of the zygomatic arches bilaterally. In terms of your exposure, you should have sufficient contrast and density so that you are able to visualize the zygomatic arches. Try and avoid using AEC exposures. Maybe try and use manual exposures as per your department protocol. In terms of your medical legal requirements, that's as we mentioned previously, your area of interest, you should be able to see your zygomatic arches bilaterally without superimposition on any of the other facial structures. So moving on to your orbits, basically your routine projections is your parietal acanthion view or your Waters method, which we have discussed previously, as well as a parietal orbital oblique view. Now this view, you really get it. It is a bit difficult. If you are not completely happy with the understanding of how to position, please refer to your Bontrager book to get more information as well as your notes. So to demonstrate your parietal orbital oblique, basically your patient ideally should be lying down on a bed in a prone position so that the mid-sagittal plane is perpendicular to your image receptor. Okay, so we need to adjust the patient's neck so that the AML, which is now your acanthion meatal line, needs to be perpendicular to the image receptor. So we're just going to feel just below the nose, meatal, so perpendicular. So our patients are really more or less that line, perpendicular to your image receptor. From this position, we need to adjust the patient's head so that the patient's chin, cheek and nose is against the image receptor. So I'm going to turn my patient's head, adjust it so that the chin, the patient's cheek and the patient's nose is against the image receptor. Okay, it is a bit uncomfortable for the patient, so remember to be gentle and be careful of how you're positioning. Then we need to rotate the patient's head about 37 degrees, more or less around this area here. And basically what we need to do is from the mid-sagittal plane, which is more or less around here, to the portion that is against the image receptor, that degree basically needs to be about 53 degrees. If you have an angle indicator in your department, that would be great, you could use it. However, we do not have one here, so we're just going to assume that this is more or less a 37 degree positioning. Your centering for this patient, basically we are going to center in the mid portion of the downside orbit. So the downside orbit is the left side, so I'm just going to bring my finger more or less, that's your area that we need to center at. Sorry, so just around there. So there's our patients here, and then we just need to collimate as well. Okay, remember to place your marker. We're demonstrating the left side, so we can put our marker unreadable on the left side of your patient. So evaluation criteria for the parieto-orbital oblique view, which is mainly done to illustrate the optic foramina. So in terms of positioning, you should have adequate positioning when you are able to see the optic foramen in the lower quadrant of the orbit. The acanthomeatal radiographic line, or your AML line, should be perpendicular to the image receptor for adequate positioning. In terms of exposure, you should have sufficient exposure to be able to visualize the optic foramen, and then no motion is evident when you are able to see your sharp bony margins. Remember to take note of your medical legal requirements. Your image should be in the center, or your area of interest should be in the center of your image, and remember that you need to have very close four-sided collimation.